Okay, welcome everybody to our 2024 virtual education conference from the Neuroendocrine Tumor Research Foundation. We're really excited to have you here today for our virtual tumor board. We have a great team. We have Dr. Soares from the University of Utah, Dr. Ahmed Chauhan from the University of Miami, Dr. Mark Lewis from Intermountain in Salt Lake City as well, and then Dr. Ahmed and Dr. Liao, as well as myself from the University of Chicago. Again, thank you for being here today. So let's dive right into it. This first case is a 50-year-old female with diarrhea that presents with diarrhea, flushing, and abdominal cramps. She goes to the emergency room. She also reports some weight loss. A CT abdomen pelvis shows numerous hepatic lesions, as well as a 2-centimeter ileocolic lymph node. And she gets worked up for this. She gets a colonoscopy and a liver biopsy that eventually show a well-differentiated small bowel neuroendocrine tumor with a Ki-67 of 10%. A serotonin level is quite high at 1330. That's much higher than normal. As we all know, usually serotonin levels are below 200 or 250, depending on the laboratory. And so as a workup, she gets a CT scan. This is the one from the emergency room that, as you can see, shows numerous lesions in the liver here, but then the blue arrow points towards the primary tumor within the small bowel here, the distal part of the small bowel. She gets a dodectate PET scan, which shows numerous lesions within the liver, as well as the primary tumor and the ileocolic lymph nodes that were seen on the CT scan in the emergency room. And then she also gets an MRI with EOVIST, which shows, like the radiologist would call it, innumerable bilobar hepatic lesions. Certainly you can't count them, but there are quite a bit here. So she is being started on long-acting octreotide as first line, as we all know, both for symptom improvement as well as for tumor improvement. And she reports some mild improvements in her diarrhea and flushing. So before we move on to the next part of what we did, I would ask perhaps Dr. Soares whether there is anything else that she would want to do at this sort of early stage. And you will see this is a multi-year story. So obviously this is the very beginning. After the diagnosis, a lot of things are going to happen. But is there something in particular at this point? You have a patient that has some mild improvement in her diarrhea and flushing, still reports some cramping. You've seen the images. Is there something else that you would recommend that we do at this time, or would you just continue to follow her?
Thank you so much. Unfortunately, this is a presentation that we see not so infrequently as the first presentation. I think obviously there is the concern that all this is related to carcinoid syndrome. So in addition to the serotonin, I'll probably get to complement that a 5-HIA, potentially pro-BNP and an echo, depending on the results, to rule out carcinoid heart disease as part of the screening. That's in terms of thinking about some of the issues with her carcinoid syndrome. Then, because of her tumor intact in the small bowel and the history of cramping, there certainly, I think, deserves a conversation about resection of the primary tumor, because that can improve her symptoms. Whether or not, consideration for liver debulking can be considered, I think it really depends on the institution that the patient is being seen. Some institutions are more aggressive than others. There's data that suggests that debulking up to 70%, if is achievable, can also improve survival, at least in retrospective analysis. So all these are considerations for this patient. Consider resection of the priming, whether or not there's a role for liver debulking. And again, that's a larger conversation. And we shouldn't forget about screening for carcinoid heart disease. These are initial thoughts. I'm sure there's more from my colleagues.
Dr. Chauhan, anything you want to add to this?
Yeah, with such high serotonin, I think I always worry about getting a baseline screening for carcinoid heart. So Dr. Soares covered those bases. The other thing that we can potentially add on here is maybe Zermello. This patient is still having carcinoid syndrome diarrhea, which is technically refractory to SSA alone at this point in time. It's not fully resolved. So that's the classic FDA-approved indication for Zermello or telithrostat ethyl. Now, this drug it targets the production of serotonin in the neuroendocrine tumor cell, unlike SSA, which blocks the secretion of serotonin. So it really complements. And if diarrhea is still a quality of life limiting issue for this particular patient, we can certainly add Zermelo, and that have shown to improve Garcia syndrome diarrhea. But beyond that, for medical management for metastatic disease, I think the case needs to be reviewed in a multidisciplinary setting to really chart what's the next best treatment. I think Dr. Soares brings out a good point about debulking for functional nets that could be hugely beneficial. But in this particular case, some might say there's too much of disease, unless there's a concern for bowel obstruction, maybe surgical debulking can be, we can trend the tumor biology, tumor growth rate. This is a grade 2 tumor, and those Ki-67 10% can be very tricky. That's really the borderline where they can be either aggressive or very indolent. So understanding the biology of the cancer, is a fast-growing grade 2 or slow-growing grade 2? It's very important. There are other therapies like liver-directed therapies that can be used. Those are relatively less invasive as compared to a debulking surgery for immediate relief or some sort of cytoreduction if it's needed for functional neuroendocrine tumor management. So again, we have multiple tools, and I think we have to factor in patients' risk for individual procedures, their choices, and their goals, and also factor in the multidisciplinary tumor board recommendations and what expertise are available. For example, you guys at University of Chicago, you're very well known for NET surgeries. Not every center might have very expert NET debulking surgeons. So we got to factor those things in.
Thank you very much. So to both yours and Dr. Soares' point, we obviously got an echo that was all negative. She also had no symptoms. I would also add that occasionally, patients, certainly with carcinoid heart disease, don't have any symptoms. So no shortness of breath, no swelling over legs. And still, I don't know what your thoughts is, but generally we tend to, once the serotonin level are above 1,000, even if there are no symptoms, we tend to definitely check for that, especially if we plan on doing something a little bit more on the invasive side. This case was presented in the Neuroendocrine Tumor Board, and believe it or not, we judged this, for at least from a liver perspective, to be too high tumor burden for debulking. Like Dr. Soares said, there's different thresholds. We generally try to aim for greater than 90% because those are the better results that we've seen, especially in very symptomatic patients like she is. But, we just thought there was too much. However, one of the things that I think you both mentioned as well is to really pay attention to the patients, right? So in this particular case, her crampy abdominal pain didn't really resolve. And if you remember from the CT I showed you, that lesion was almost completely obstructive in the small bowel lumen. And so we did decide to take her to the operating room or to remove the primary tumor. We thought that this was necessary to relieve her symptoms that she had, not so much the flushing and the diarrhea, but rather the crampy abdominal pain and the weight loss that she had. And so we did a laparoscopic right hemicolectomy. We took her gallbladder out, which we often do in patients with metastatic disease that actually are projected to be on long-acting octreotide for a while. And then we did a liver wedge resection just to be sure that we're dealing with the same Ki-67 or tumor grade, like you said, Dr. Chauhan, which is really important to understand sometimes for tumor biology in the primary tumor as we see in the liver. And so it turned out that the operation went very well. She recovered quickly. This was a small bowel neuroendocrine tumor, well differentiated, grade 2, 3 out of 27 positive lymph nodes, and a Ki-67 of 6% actually. Now, we, for some reason, run OncoPlus, which is molecular testing platform on all our neuroendocrine tumors, including the small bowel neuroendocrine tumors, which generally is not that helpful for small bowel neuroendocrine tumors. But these were the results. She was found to have 2 pathogenetic findings, one a mutation in BCOR, which is really, I think, a loss of function mostly, and then an equivocal Notch1 loss. Anything any of the medical oncologists wants to add here that makes you nervous, unnervous? I know BCORs can be found in small bowel neuroendocrine tumors, but I don't think it has any particular prognostic value. Anything you want to add before I move on?
Yeah, I don't know we know enough about prognostic or predictive value of these two.
I would agree. I think Notch1, we are increasingly learning Notch pathway signaling in general, broadly with neuroendocrine cancers, definitely well established with higher grade, poorly differentiated neuroendocrine carcinomas. But again, this is one of those biomarkers not we don't understand what they mean, and they're not very commonly found either. So I think it's too difficult to make sense of these things at this stage of time.
I might just add, maybe the one time I do find genomics fairly helpful in these settings is, as we all know, there are occasionally times, at least before patients go to the operating room, where you might actually not be able to distinguish readily a pancreatic from a mid-gut primary. I certainly see that from time to time. And there I find loss of heterozygosity in chromosome 18 to be a hallmark of the mid-gut origin. So that's sometimes helpful. But yeah, I agree. I wouldn't see anything actionable here.
Okay, so she's continued to have symptoms despite being on long-acting octreotide, or in this case, lanreotide, 120 milligrams every 28 days. So what now? Anybody wants to chime in and think about, anything else we could do for this patient that still is symptomatic? Obviously, her cramps go away. That's not an issue anymore, but she still has the flushing and the diarrhea.
I think like Dr. Chauhan said, telotrestat or Zermelo is an option, but controlling the symptoms also goes hand in hand with controlling the disease. So, if the tumor is not debulkable by surgery, then perhaps we could consider liver-directed therapy, otherwise a different type of systemic therapy.
Great. So Dr. Ahmed, can you talk to us a little bit about liver-directed therapy in neuroendocrine tumors, specifically in those cases where liver debulking is not a good option, either because the patient, couldn't get through it or because the tumor volume is too high?
Quick comment before we go. So it might not be fully serving this particular case, but after the debulking or primary tumor resection, for the audience, it's important to know the diarrhea in neuroendocrine tumor can be multifactorial, and especially after the surgery, short gut diarrhea can be particularly playing a role now in addition to carcinoid syndrome diarrhea. So it'll be interesting to see how the serotonin levels or 5-HIA levels trended pre and post operatively, so that we can really fine tune. If it is purely a carcinoid syndrome diarrhea issue, then again, I think we will hear more about what we did to debulk further disease. But if there are additional components, some patients might get gallbladder removed, who might have some bile acid diarrhea component, bacterial overgrowth, short gut syndrome. So it's really important to understand what could be contributing to worsening GI issues.
Yeah, it's a very good point, especially as we remove the right colon, the terminal ileum and the gallbladder, you could have bile reabsorption issues, which hopefully most surgeons will know about. And so if the diarrhea gets worse, you would definitely expect that there's a component there. In her case, the diarrhea pretty much remained the same, and the serotonin level, I'll show you in a little bit, was also about the same. So we assumed that this was serotonin-induced diarrhea still at this point. Back to our IR colleagues.
Yeah, sounds good. This is honestly, where I think there's a nice role for what Dr. Chauhan talked about in terms of local regional therapy. So from an interventional radiology perspective, we have a role when patients have disease, especially localized to one organ, particularly the liver. And we tend to sort of work well when you have a lot of tumor in the liver or very little, like 1 or 2 lesions. And so in this case, as Dr. Keutgen mentioned, there was a lot of tumor in the liver, so much that, sort of going in there surgically and removing all of it doesn't seem possible, or would potentially be more risky than beneficial. So the way that we treat tumor when there's a lot of tumor in the liver is through what are known as intra-arterial therapies. And intra-arterial therapies is where we take a catheter through the groin and we thread it through the artery, very small catheter, about 1 or 2 millimeters in size. Using X-ray guidance, we can take it into the liver, and then we can inject material through that catheter. And depending on what we inject is what the procedure is known as. For patients with neuroendocrine tumors, we most often do what's known as bland embolization, where we inject basically inert beads, almost like grains of sand, essentially, to plug up the arteries and starve the tumor of its blood supply. As you can see here from the PowerPoint, because there's tumor in both the right and left lobes of the liver, we can treat the whole liver, but we typically have to split that up into 2 procedures, because treating half the liver at one time is a lot to recover from. And then so patients usually need about a month or so to recover from that, and then we can treat the other side.
Great, thank you. And obviously I didn't give you a real time frame here, but this happened relatively shortly. So the first few slides here I showed you happened within 3 to 4 months. So I think one of the issues which we haven't touched based on directly, but it's not always about biology and tumor progression, but also I think about quality of life. This patient was a highly functional patient that worked full time, was a mother to 3 children, and had to go on with her life. So she really was bothered by the diarrhea, which was really keeping her from doing a lot of the things she would normally do. So she sort of, needed to move on. And that's why we don't necessarily have to be that aggressive with most patients, but quality of life, I think, is a really important part, especially with carcinoid syndrome. And so I think that it's important to consider that. So her symptoms did finally improve after Blan-Embo. Her serotonin level went down by almost 1,000 points to 364. So that's a pretty good success. And I think it also speaks for, the knowledge and the savoir-faire of our interventional radiology colleagues. But, about 6 to 8 months later, she came back to clinic. And again, we're scanning her in the meantime, no major changes, but she reports worsening symptoms again, and her serotonin shoots back up. But the MRI read at the time, says that things look grossly stable. Is there anything you would want to do at this time point? Maybe Dr. Soares, you could comment if there's anything else that you think this patient would need.
Again, it's all about the conversation with the patient and goals of care, because there's other strategies. If you believe really the disease is stable, it's just progression of the functional status, then you can discuss, in addition to the litrostat, you can discuss strategies to increase the frequency of the somatostatin analog or the dose if you are in octreotide, and if you are in lanreotide, you can do every 2 weeks. But this is a patient that actually, if we think about an error to study that was recently presented and published with a Ki-67 of 10% and quality of life being something very affected, and the high tumor burden of disease, it's not unreasonable to consider here are 3 treatments. Again, depending on the conversations with the patient, is at least worth the conversation here. And 6 months later, you can argue that would you want to try more liver embolizations? I personally prefer to see at least a good year of benefit before trying again, but it's certainly conversations that can take place.
Yeah, very good. So I think, like you suggested previously, starting her on telorastat was thought to be the next step because, again, she was very active, she was working, she didn't want anything really more at that time. And this was sort of an easy thing for us to just do. But unfortunately, she didn't have any major improvements in her symptoms.
And may I just ask, did she stay on the litrostat for a good 3 months?
Yeah, she did. So we'll make sure that she always tries 8 weeks at the minimum. I think it's an important point you bring up because symptoms may not improve within 2 weeks. We know that, right? So we generally tell our patients to stay on it for at least 2 months before they stop. So we got to repeat dotatate PET because, I think it's important to remember that MRIs sometimes will show obviously what happens in the liver, especially when you have a lot of liver disease, confluent liver disease like she has. It's sometimes challenging to really assess true progression. I don't know if you've found similar things, but she got a repeat dotatate PET, and the dotatate PET showed worsening of her liver disease as well as some new retrocrural lymph nodes. So sort of a very mild and small extrahepatic disease. Dr. Lewis, at this point, symptoms getting worse, clearly had some progression, some, although very small amount of extrahepatic disease. Anything you would recommend that this patient be started on at this time?
Yeah, I think I'll combine my colleagues' comments, which I thought were extremely insightful. The word aggressive has always struck me as very subjective. So sometimes patients will ask me, even at the very first visit, doctor, is this aggressive? I like the way that Dr. Chauhan put it, that, honestly, disease biology will declare itself in time. And the Ki-67 of 10% is really an interesting sort of liminal number that, yes, is grade 2, but as he was saying, can kind of go either way. And so I would, again, reiterate what Dr. Soares was saying, that as of this year, as of ASCO GI, and the publication of the NETRF data, which of course places PRRT with somatostatin analogs right up front, I would strongly consider PRT given this dotatate PET, which really by the lock and key hypothesis shows that there is still disease that's targetable, not just with analog, but with therapeutic radionuclide.
So this is exactly what we did. We started on PRT. She had improvements in her symptoms, and her serotonin level ranged from 274 to 406 over the treatment period of 8 months. So she definitely improved dramatically and probably felt the best that she had in many years. A repeat dotatate PET-CT a year later showed stable disease. You even see maybe some of this extrahepatic disease. These retrocrural lymph nodes are not as obvious anymore on the dotatate PET. But 2 years post-PRT, her symptoms worsened again, and her serotonin crept back up again above 1,000. So what now, Dr. Liao? Any recommendations?
Yeah, I think, we would be worried about disease progression. And then the question is it mainly the liver or outside the liver? Because our treatment options may be different. So if it's within the liver, we may still be able to consider something liver-directed, such as embolization or debulking, which is now the candidate. But if it's more systemic progression, then we will choose another systemic therapy. So I think the MRI here shows mainly liver progression, right?
That's right, yeah. So this is a really interesting case because what ended up happening, and you have the two dotates next to each other here within a year period, is that she mostly had progression of a single lesion in segment 2 that sort of rapidly appeared out of nowhere. And she had some progression in segment 4, but not dramatic. Really, it was the segment 2 lesion here that you could see very clearly on the dotatate that really significantly changed, came out of nowhere. So, Oz, from an IR perspective, anything you can offer for a lesion? This measured about 3.5 centimeters.
Yeah, definitely. So this is now we're talking about sort of the other spectrum where we often are asked sort of evaluate patients is when you have maybe one lesion in this situation that's growing out of control, whereas the rest of the disease is stable. So when we're trying to target just one lesion, we can start thinking about some of our percutaneous treatments, which are treatments through the skin directly into the tumor. And that's specifically ablation is one good option. Ablation is where you take a needle through the skin directly into the tumor. You can either burn it or freeze it or even electrocute it. Ideally, we like to do it for lesions that are 3 centimeters or smaller because those tend to be treated best. And again, depending on the location, we can also do very focal embolization as well. So I don't recall what we did here, but this does look like it's in a favorable location for ablation.
Right. So, yeah, in this particular case, I have to smile because Dr. Chauhan, before we started the tumor board, said, well, the case you're going to present, the answer is easy. Everybody goes through surgery. Well, this was presented at tumor board and we went back and forth and we thought that certainly we could destroy this, but we weren't sure whether percutaneous approach would really significantly help her symptoms. And so we also wanted a good chunk of tumor because we wanted to run some more additional tests, especially to see whether this is a tumor that is slowly de-differentiating. So we sort of bit the bullet, and I gotta tell you, this is not generally cases that I as a surgeon like to debulk because like I said, we generally aim to go over 90% debulking, which clearly, look at the dotatate PET, in this case is not possible. But we did take it to the operating room and we removed quite a bit of tumor. So you can see here multiple deposits ranging from 4 to 8 centimeters, essentially. So, looking at putting all of these tumors together was basically bigger than an orange in terms of what we were able to remove. The fascinating part was this. So we asked our pathologists to specifically look at different blocks, and the segment 2 turned out to be with a Cat67 of 20%. The segment 5, which was the other one, 4, 5 that was growing, was 12.5%, and the other ones were 1%. So this, I think, is a really interesting finding. I'm curious to see what the team is going to say about this. But before I give you the floor, I will add that again, we run an OncoPlus, and again, it showed a B-core mutation, but also now we had a SMAD4 loss and perhaps more importantly, an RB1 loss. So when you see this report here, and I know we don't always get to see reports like this after PRT, after liver-directed therapy, to have so many multiple samples, but what runs through your mind? Let's start with Dr. Soares.
Yeah, it certainly is concerning that, things are picking up more speed. We tend to see this RB1 in more loss in more aggressive tumors. So that goes along with the imaging that we're seeing in the growth of some of the lesions.
Dr. Chauhan, how often do you see this heterogeneity of Ki67s within tumors?
Actually, quite frequently, especially in the era of heightened PRRT use, and also in PNETs where people have gotten alkylator-based chemotherapy for a long period of time. I'm seeing a lot of grade migration and aggressive or upregulation of the grades. So this is not uncommon, and rarely I'm also noticing complete transformation from well-differentiated to poorly differentiated neuroendocrine carcinoma as well. This particular case, it looks like kind of genetic fingerprinting it's acquiring, like loss of RB1, which is more like pathognomic of neuroendocrine carcinoma rather than neuroendocrine tumor. These tumors are definitely evolving and getting more aggressive as we can see here. So I'm glad that you did do the biopsy or at least surgical debulking so you can understand that. So if I see rapid growth in otherwise indolent disease, I'm worried about grade migration and kind of worsening of the tumor biology. And I'll almost always do a biopsy. And I also like to do both dotatate and FDG PET in these cases, because what happens in these heterogeneous diseases, you have to really target the more aggressive biology first. So you have to understand which lesions are more hypermetabolic and which are more SSTR positive, negative, to really get a very comprehensive understanding of whether you're going to in future need chemotherapy or you'll be okay with some sort of targeted therapies.
Yeah, and postoperatively, her serotonin dropped to 4.4, her symptoms improved. So that's obviously positive for us. But to what we've discussed right now, I think that certainly this is not going to be a case. It's just gonna, sit quiet for a while. It has for the last 3 months or so, but we expect that something again within the next 6 months is going to change. I guess that occasionally you could be lucky and just have wedged out just the one clone. There was the problematic one, but similar to what you said, we do think that generally this has changed overall in terms of probably multiple foci throughout this liver that now have more aggressive features. Dr. Liao, if this patient recurs relatively rapidly, and assuming there are no FDG positive lesion, but still high uptake on dotatate, would you consider retreatment with PRT? Or would you, because of the Ki67, likely go to a chemotherapy-based approach next?
I'll consider retreating with PRT, given that it seems like she had a good progression-free interval with the first course of PRT. And we're seeing more and more data, from the NETRF for the activity in PRT for the higher grade disease. Now, had the biopsy shown something different, with the RB loss, had it shown poorly differentiated neuroendocrine carcinoma with a very high Ki67, like 70%, I would probably move on to chemotherapy instead.
Dr. Lewis, do you think the clonal change here, so the changes of the neuroendocrine tumor cells, perhaps getting a little bit more aggressive with a high Ki67, is due to PRT?
Oh gosh, that's an excellent question. I would infer that not. I liked what Dr. Chauhan said, that in the era of more and more alkylator use, and of course we see sort of CAPTEM used more and more, especially in our PNET patients, temozolomide certainly has the sort of hypermutational profile. We sometimes do that on purpose, actually, to try to raise, say, candidacy for immunotherapy. Just based on our understanding of the rates of your therapy-related MDS with PRT alone, meaning without alkylators, I think it's less likely that temozolomide did this. I do like the points you're driving home here, though, that when the disease is not acting in a manner that is congruent with your understanding of the proliferative rate, I think we are obligated to obtain more tissue. And I think it's really important to get across this point of heterogeneity. Dr. Soares and I are involved in a very active support group here in Salt Lake. And just as most breast cancer patients would know their ER, PR, HER2 status, the leader of the support group here almost inculcates in our members and our patients that they need to know their Ki67. I think the problem is the overly simplistic assumption that the Ki67 is static or is homogeneous. And as Dr. Chauhan said, we sometimes see what I would say is sort of a solid tumor version of a Richter's transformation, where you go from a relatively low-grade biology to something much more threatening. And again, this is happening, as you've shown very elegantly, in the same patient at the same time. So I always focus my efforts on what I think is the most aggressive, and sometimes that means the most unexpected. Like you said, that segment 2 lesion just kind of popped up, and you showed that very nicely. And, short of a very extensive surgery like you, I think very expertly performed, I think I would have sampled the segment 2 lesion and then based a lot of my treatment decisions around that.
Great. Thank you very much to all of you for participating in this neuroendocrine tumor board. I hope our patients will find this helpful. This was really, I think, a very fruitful and very insightful discussion. So thanks again for being part of this, and we will see you very shortly for the Q&A. So thank you very much.